Okay, in our video series of endocrinology lectures, in this video, we are going to talk about hyperthyroidism. We are going to discuss the presentation, the causes, the diagnosis, and the treatment of hyperthyroidism in detail. A 32-year-old anxious lady comes to your clinic complaining of weight loss. Doctor, I have been losing weight for the last few months. Doctor, I have been having this chronic diarrhea all the time. I have been taking many treatments and many medications to stop the diarrhea, but it is not resolving. Doctor, I feel that my heart is pounding in the chest. I have these palpitations all the time. Doctor, I feel that I am sweaty while the others are feeling cold. I feel that my body is very warm. When you examine the patient, there is a staring look in the eyes like this. There is fine tremor present in the hands. She complains of anxiety. She complains of being in stress all the time. This is a classical presentation of Graves' disease, which is a form of hyperthyroidism. What is hyperthyroidism? How do you diagnose it? Today we'll discuss that. Hyperthyroidism is a condition characterized by overproduction of the thyroid hormones by the thyroid gland. Thyroid gland is a gland that is present in our neck in front of the trachea that produces thyroid hormones. And as we discussed in our video on hypothyroidism, these thyroid hormones are the fuel of the body. They run the machinery. The machinery is the body and the fuel is the thyroid hormone. And when there is more fuel, the body is on fire. So literally, every organ of the body is running very fast, is hyper functioning. That is what is happening in hyperthyroidism. Basically, where does these thyroid hormones come from? Hypothalamus in the brain signals the anterior pituitary through thyroid releasing hormone to secrete a hormone called as thyroid stimulating hormone. So signal from hypothalamus releases thyroid releasing hormone. Thyroid releasing hormone acts on anterior pituitary and releases thyroid stimulating hormone. Thyroid stimulating hormone acts on the thyroid gland present in our neck, and that thyroid gland then produces thyroid hormones. These thyroid hormones include T3 and T4. And remember, T3 is the active form of thyroid hormone. This T4 gets converted to T3 in the peripheral tissues, and T3 is the more active form of the thyroid hormones. And in hyperthyroidism, there is excess of these thyroid hormones. Now, before going ahead, you must be clear about two terms, hyperthyroidism, and you will also have heard about thyrotoxicosis. What is the difference between these two? Remember, thyrotoxicosis is inappropriately high levels of circulating thyroid hormones irrespective of the cause, irrespective of the source. Wherever these thyroid hormones are coming from, maybe these are some cancers present in the ovaries, maybe it's the pituitary adenoma, maybe it's from the direct thyroid gland. So irrespective of the source, maybe the patient is taking thyroid hormones from outside, levothyroxine tablets. So irrespective of the source of these thyroid hormones, if the patient is having symptoms of hyperthyroidism, that is called as thyrotoxicosis, the inappropriately high levels of circulating thyroid hormones irrespective of the cause. But when these thyroid hormones are specifically being secreted by the thyroid gland, that is called as hyperthyroidism. So there is a difference between thyrotoxicosis and hyperthyroidism. Now, what are the causes of hyperthyroidism? Remember, the most common and the most important cause in 80% of the cases is Graves' disease. Second cause is toxic multinodular goiter. Third cause is thyroiditis. We'll discuss each of these causes in detail now. Other than that, iodine-induced hyperthyroidism is also a cause of hyperthyroidism. Other than that, struma ovariae is a very important cause, and that is highly tested in exams. They will ask you the patient is having some ovarian tumor, and that ovarian mass is causing the symptoms of hyperthyroidism, and they would expect you to know that this patient is having ovarian teratoma, that is called as struma ovariae, and struma ovariae contains thyroid cells, and that ovarian tumor secretes these thyroid hormones and causes symptoms of thyrotoxicosis. Other than that, pituitary adenoma, there can be a mass present in the pituitary gland that secretes thyroid stimulating hormone and makes the thyroid gland secrete more thyroid hormones. Other than that, a commonly tested point in exams is also hereditary mole. They would give you a scenario that a patient is pregnant and that patient is having signs and symptoms of hyperthyroidism. When you perform the ultrasound scan of that patient, you would see that that patient is not having any pregnancy. That patient is having a hydatidiform mole in the uterus, and that hydatidiform mole in the uterus mimics pregnancy, and that hydatidiform mole secretes excess amount of beta HCG, and that beta HCG mimics, it resembles TSH and stimulates the thyroid gland to secrete thyroid hormones. So hydatidiform mole is a cause of hyperthyroidism. Radiation can damage the thyroid gland and release the preformed thyroid hormones. So these are some causes, but now we will go into the most important causes of hyperthyroidism, and that is the Graves' disease. Graves' disease is the most common cause of hyperthyroidism, and it is autoimmune condition, most common in middle-aged female. Like other autoimmune condition, it is also common in middle-aged females. Basically, what happens in Graves' disease is that antibodies are formed, and those antibodies bind to the TSH receptors present on the thyroid gland. These antibodies bind to the TSH receptors and they stimulate the TSH receptors, and they cause secretions of loads and loads of thyroid hormones from the thyroid gland. So these are actually TSH receptor autoantibodies, and they stimulate the thyroid gland to an extent that they cause excess production of thyroid hormones from the thyroid gland. That results in the Graves' disease. These antibodies include TSH receptor antibody, TRAB. These also, you will also hear about antibody called as LATs, long acting thyroid stimulating antibodies. So these are basically antibodies, and they stimulate the thyroid gland to produce excess amount of thyroid hormones in the body. Now, when you have a patient with hyperthyroidism, a test that you perform in these patients is called as radioactive iodine scan. Now, when you perform radioactive iodine scan in a patient with Graves' disease, what you see is that there is diffuse uptake of radioactive iodine by the thyroid gland, because whole of the thyroid gland is hyperactive, hyperstimulated, and whole of the thyroid gland will take up radioactive iodine, and it will light up the picture. So this is a picture showing a normal thyroid scan where there is uptake of radioactive iodine, and this is a patient suffering from Graves' disease, and look at the iodine uptake by the patient with Graves' disease. Look at the thyroid gland is hyperactive, and all of it is taking excess amount of radioactive iodine. So that is how you test a patient with Graves' disease. Other than that, when you examine the patient with Graves' disease, the thyroid gland is diffusely enlarged, and sometimes the patient with Graves' disease can also have a goiter, and that will be a painless goiter. The patient will not be having pain. The thyroid gland will be smooth on examination. Smooth and enlarged thyroid gland is seen in patients with Graves' disease. The thyroid gland is painless. Now, there are certain signs. If these signs are present, then the cause of hyperthyroidism is most likely Graves' disease. If you see ophthalmopathy, signs like lid retraction, lid lag. If you see ophthalmopathy is seen in Graves' disease. The cause of hyperthyroidism is Graves' disease if there is ophthalmopathy. If you see pretibial myxedema, it's very likely that it is due to Graves' disease. So Graves' disease causes ophthalmopathy and pretibial myxedema, while the other causes of hyperthyroidism do not cause ophthalmopathy. Now, that was all about the Graves' disease. Coming to toxic multinodular goiter. In the toxic multinodular goiter, what happens is it is commonly seen in patients greater than 50 years of age. Graves' disease is seen in patients with 20 to 30 years of age. In these patients, what you see is that there will be an enlarged goiter, and when you examine the goiter, it will be of a nodular pattern. In Graves' disease, the goiter can be smooth. In toxic multinodular goiter, there will be hyperthyroidism, and the goiter will be nodular. Basically, it happens due to chronic iodine deficiency. In areas where there is chronic iodine deficiency, the TSH will stimulate the thyroid gland, and thyroid gland would get enlarged. But now when these patients take iodine, their thyroid gland is very enlarged, the tissue is enlarged, and it will take up small amount of iodine, and it will produce excess amount of thyroid hormones. So when these patients get iodine from their diet, their thyroid gland is enlarged, and their thyroid gland will take up all of the iodine, and it will produce excess amount of thyroid hormones. So initially the thing starts with chronic iodine deficiency, they develop goiter, and when they get iodine in the diet, the tissue is enlarged, and that tissue will produce excess amount of thyroid hormones. When you examine the goiter, it will be nodular and it will be painless. And when you perform radioiodine scan, you will see multiple foci of uptake because there are these nodules that will take up the iodine and produce excess amount of thyroid hormones. So this is a normal thyroid scan, and when you perform thyroid scan in toxic multinodular goiter, this is the picture that you see. These are the nodules that are producing excess amount of thyroid hormones. Coming to the third cause, thyroiditis. What happens in thyroiditis is that thyroiditis is actually destruction of the thyroid gland. Now we discussed thyroiditis in hypothyroidism, and we are also discussing it in hyperthyroidism. Basically what happens in thyroiditis is that there is destruction of the thyroid gland due to any infection, due to immune mediated reaction. So there can be destruction of the thyroid gland either due to infection or due to immune mediated reaction. But that destruction of the thyroid gland will release preformed thyroid hormones in the body, and there will be excessive surge of thyroid hormones in the blood that will cause the signs and symptoms of thyrotoxicosis and hyperthyroidism. But after that signs and symptoms of hyperthyroidism, that patient will ultimately go into hypothyroidism because the thyroid gland is damaged. So initially in the patients with thyroiditis, there will be a hyperthyroidism, but after some time the patients will develop a hypothyroidism due to destruction of the gland. So that is a cause of hypo as well as hyperthyroidism. In thyroiditis, there is transient thyrotoxicosis followed by features of hypothyroidism. When you perform the radioisotope scan, since there is destruction of the thyroid gland and thyroid gland cannot take up the radioactive iodine, so there will be reduced uptake in patients with thyroiditis. Now there are certain antibodies that are also involved in the pathogenesis of thyroiditis, like anti-thyroid peroxidase antibodies. If you perform thyroid scan in these patients, there will be reduced uptake because there is destruction of the thyroid gland, so the thyroiditis will show reduced uptake. Thyroiditis is divided into two types: subacute granulomatous thyroiditis, also called as dequervin thyroiditis, where there is an infection in the body and that infection destroys the thyroid gland and releases thyroid hormones. So a viral infection, mycobacterial infection, can cause subacute granulomatous thyroiditis, and the thyroid gland on examination is painful. Remember, very important point. Subacute lymphocytic thyroiditis, also called as silent thyroiditis, where the thyroid gland is painless. So the difference between these both is that in subacute granulomatous thyroiditis, the thyroid gland will be painful, but in subacute lymphocytic thyroiditis, it is silent, it is painless. It is caused by postpartum. Right after giving birth to the baby, patient develops signs of hyperthyroidism because of the destruction of the thyroid gland, that is immune mediated destruction, autoimmune destruction of the thyroid gland. Certain drugs can cause thyroiditis like amiodarone. Amiodarone can cause hyperthyroidism as well as the hypothyroidism. Lithium can cause subacute lymphocytic thyroiditis, and thyroid gland is painless. Now coming to some really important and interesting phenomena that you will be tested about in exam many times: Jod Basedow phenomena and Wolff Chaikoff effect. What happens in Jod Basedow phenomena is that there is iodine-induced hyperthyroidism. Iodine-induced hyperthyroidism occurs in patients that are living in areas where there is low amount of iodine in the nutrition. People living in areas where there is low amount of iodine in the nutrition, their thyroid gland get accustomed to low amount of iodine in the nutrition, and it produces thyroid hormones from that small little amount of iodine that it is getting from the nutrition. So their thyroid gland will produce thyroid hormones from the iodine that it is getting, but their receptors are upregulated to take up that small little amount of iodine that is being absorbed from the nutrition. When these patients living in the areas where there is low iodine and their thyroid glands with upregulated receptors for the uptake of iodine, when they come to the areas where there is increased iodine in the diet, people taking iodized salts, when they take up these type of salts and these type of nutrition with excess amount of iodine, their thyroid hormone, their thyroid gland takes up all the iodine, and it is very happy that now I am getting loads of iodine that I did not used to get before. So it starts taking up more and more iodine, and it starts producing thyroid hormones, resulting in iodine-induced hyperthyroidism. That is called as Jod Basedow phenomena, and it occurs in people living in iodine-deficient areas where the thyroid gland is accustomed to small little amount of iodine in diet, but when they come to areas where there is increased iodine in the diet, their thyroid gland takes up all the iodine and start producing excess amount of thyroid hormones. That is called as Jod Basedow phenomena. Now coming to a very interesting phenomena called as Wolff Chaikoff effect. Wolff Chaikoff effect is a very important and interesting phenomena. Basically, if you have seen the season on Netflix called as Chernobyl, it is a very interesting season with 5 to 6 episodes in which there is explosion of a nuclear reactor in the city of Russia called as Chernobyl. Now when the explosion of the nuclear reactor takes place, there is radiations all around. All the water is having radiation, everything is having radiation. And if you have seen that season, you would see that the characters in that season are taking potassium iodide tablets, and they tell each other that take up this potassium iodide tablets, it will protect your thyroid gland from the radioactive iodine. Why does that happen and how does that happen? Basically, if you take excess amount of potassium iodide, your thyroid gland will be like, where is this excess amount of iodine coming from? And it will stop the uptake of iodine. It will stop the uptake of iodine due to excess amount of iodine present in the blood. Therefore, the radioactive iodine that is present in the water and the nutrition now, that cannot be absorbed by the thyroid gland, because the thyroid gland is amazed and thyroid gland does not want excess amount of iodine. So it is a phenomena that is opposite to Jod Basedow phenomena. Jod Basedow phenomena occurred in people that were living in iodine deficient area. Wolff Chaikoff effect is not like that. Wolff Chaikoff effects occurs in common people having normal amounts of iodine in the nutrition, but when they take excess amount of iodine from outside, their thyroid gland stops the uptake of iodine from the diet, and it stops the radioactive iodine from getting in the thyroid gland. So that is called as Wolff Chaikoff effects, and that's why these characters were taking potassium iodide from from outside to prevent their glands from taking up radioactive iodine. So that is called as Wolff Chaikoff effect, reduction in the thyroid hormone synthesis caused by ingestion of large amount of iodine. So that is called as Wolff Chaikoff effect. Hyperthyroidism is more common in females as compared to males, 5:1. Graves' disease commonly affecting 20 to 30 years of age, toxic adenoma 30 to 50 years of age, and toxic multinodular goiter, the incidence is more common in patients with greater than 50 years of age. Now coming to clinical signs and symptoms of hyperthyroidism. Remember, thyroid hormones are the fuel of the body, and when you give excess fuel to the body will be on fire. Each and every organ will be hyper-functioning. There will be excessive heat production, heat intolerance, excessive sweating to dissipate that heat off from the body, because the body is hyper-functioning. Each and every organ is hyper-functioning and producing excess amount of heat. There will be weight loss, it will burn the fat. There will be frequent bowel movement, the GIT movement will be rapid, and there will be diarrhea in these patients, weakness and fatigue due to all the overwork that body is going through. Now coming to the eye signs are seen in patients with Graves' disease. What you see is that there is lid lag. Basically, when person normally looks down, the eyelid would also go down. But in patients with Graves' ophthalmopathy, when they look down, the eyelid does not go downward because of the excessive spasm, lid retraction that is present in patients with Graves' disease. Lid retraction or staring look. Now normally the dark part of our eye, the iris of our eye, is actually covered, upper part is covered by the eyelid. But in patients with Graves' ophthalmopathy, their eyelid retracts, and when their eyelid retracts, the white part of the eye is also visible above the iris. So you will have a staring look in these patients. Look at the retraction of the eyelid, and the white part is visible above the iris. White part is visible above the iris. Graves' ophthalmopathy can involve the retroorbital areas as well, and there is edema of the periorbital tissue that pushes the eyes outward. So there is Graves' ophthalmopathy, and look at the edema of the periorbital area, periorbital muscles. There is excessive deposition of glycosaminoglycans and hyaluronic acid, and these gags attract water and they cause severe edema. These patients cannot even move their eyes laterally properly in the later stages, and sometimes it can even involve the optic nerve, It can compress the optic nerve, and compression of the optic nerve results in eventual blindness in patients with Graves' ophthalmopathy. In cardiovascular system, the heart would be overworked. When the heart is overworked, these patients will experience tachycardia, palpitations, irregular pulse, and remember, atrial fibrillation, a huge association of atrial fibrillation with hyperthyroidism. Hyperthyroidism will make the heart work more and more and more, and then the atria will go into atrial fibrillation. So in patients with atrial fibrillation, always look for hyperthyroidism, and in patients with hyperthyroidism, do ECG and look for atrial fibrillation. Hypertension, widened pulse pressure, bounding pulse in these patients, high volume pulse. You will see a high volume pulse in these patients, and there, when you check the blood pressure, the systolic pressures will be high. There will be a wide pulse pressure. Thyrotoxicosis induced cardiopathy. In the later stages, they would go into heart failure, chest pain due to overworked heart. In the musculoskeletal, when you examine their hands, they will be having fine tremors in their hands. When you place a paper, it will become more visible. There will be hyperthyroid myopathy. The proximal muscles are extremely damaged in patients with hyperthyroidism. Remember, proximal muscle myopathy is also present in hypothyroidism, but it is also seen in hyperthyroidism. And the differentiating factor, as we discussed in our previous video as well, that serum creatinine kinase is elevated in hypothyroid myopathy, but it is normal in hyperthyroid myopathy. So hypothyroidism, the myopathy elevates the CK levels, but in hyperthyroidism, the CK levels are normal. Osteoporosis, it destroys the bone. So osteoporosis, it destroys the bone, and there is excessive sweating due to excessive heat production in the body. In the endocrine, females develop oligomenorrhea, amenorrhea, anovulatory cycles, infertility, dysfunctional uterine bleeding, disturbance in the normal uterine cycles. Males experience gynecomastia, erectile dysfunction, and there is hyperglycemia in patients with hyperthyroidism. On the skin, especially in patients with Graves' disease, you will see pretibial myxedema. There will be infiltrative dermopathy. There is basically excessive deposition of the glycosaminoglycans in the pretibial area. Now remember, we also discussed about myxedema in hypothyroidism, but myxedema in hypothyroidism involves all of the body. But in patients with Graves' disease, myxedema occurs specifically in the pretibial area. So this is basically glycosaminoglycan deposition, and this is a picture showing pretibial myxedema. While in hypothyroidism, it's the all of the body that is involved in hypothyroidism. Oncolysis, separation of the nails from the nail plate. Thyroid acropathy, nail clubbing is also seen in patients with hypothyroidism, that is called as thyroid acropathy. Now if you see pretibial myxedema, ophthalmopathy, oncolysis, thyroid acropathy, this is Graves' disease. Neuropsychiatric symptoms, excessive brain function. When you think more, you get more anxious, restless, insomnia, hyperreflexia. On examination, patients with Graves' disease will have diffuse, smooth, non-tender goiter, and there might be present an audible bruit in the superior poles seen in Graves' disease. Now coming to the investigations of hyperthyroidism. Remember, hypothalamus produces thyroid releasing hormone that acts on the anterior pituitary secretes thyroid stimulating hormone that acts on the thyroid gland to produce thyroid hormones. So you have to test the T3, T4 levels as well as the TSH levels. And T3, T4 levels will be high and TSH levels will be low, especially where there is thyroid gland producing excess amount of thyroid hormones. Sometimes it can also happen that there can be a pituitary adenoma, a mass in the pituitary gland that secretes excess amount of TSH, and TSH will be elevated with an elevated T3, T4. So if the TSH is also elevated, it means there is pituitary adenoma. If the TSH is low, it is most likely Graves' disease. So in a patient with hyperthyroidism, you perform the thyroid function test, you check the TSH level. The TSH level is low and total T3 and free T4 is high. It means that the patient is having overt hypothyroidism. Thyroid gland is producing excess amount of thyroid hormones. If you perform the TSH level and TSH level is high with a total T3 elevated as well as a free T4 elevation, this means that that patient is having a pituitary adenoma, a mass in the pituitary gland. That pituitary adenoma is producing thyroid hormones, and you need to perform MRI of the pituitary gland because excess TSH indicates that there is a mass in the pituitary gland. You perform the MRI and you see a mass like this, a mass like this. This means that there is a mass producing TSH that is stimulating the thyroid gland to produce excess amount of thyroid hormones. There can be another scenario where when you perform the TSH levels are low, but the T3 and T4 levels are normal. What does that mean? That means that previously there was a certain amount of TSH that stimulated the thyroid gland to produce thyroid hormones. But now the pituitary has to work less on the thyroid gland and has to produce less amount of TSH to produce the same amount of thyroid hormones. It means that the thyroid gland is overactive. That thyroid gland does not need stimulation from the pituitary gland and it can produce thyroid hormone all by itself. This is danger sign. This means that thyroid gland is overactive and it does not need stimulation from the pituitary gland. TSH is low and T3, T4 are normal. It means that the patient is ultimately going to hyperthyroidism. So it is called as subclinical hyperthyroidism. Just like subclinical hypothyroidism, there is subclinical hyperthyroidism as well, where the TSH stimulation is not needed for the T3, T4 production, and it means that that patient will ultimately go into hyperthyroidism, overt hyperthyroidism. Now, if you have a female patient with hyperthyroidism, low TSH and increased T3, T4 or normal T3, T4, a good thing to do is to perform beta HCG levels. In female that is of childbearing age, you should perform beta HCG level because sometimes there can be a choriocarcinoma hydatiform mole that is producing excess amount of beta HCG and resulting in stimulation of the thyroid gland. You perform beta HCG level and you rule out gestational thyrotoxicosis. It is not applicable in all cases, only in specific patients that are having pregnancy. You check the beta HCG levels to rule out that whether it is gestational thyrotoxicosis or not. Other than that, you look for the signs of Graves' disease. You look for ophthalmopathy, pretibial mixed edema, acropathy and clubbing. If you find these, most likely this is Graves' disease. If these are present, this is Graves' disease. And then the next test you perform is you check the antibodies, anti-thyroid receptor stimulating antibodies. If these are absent, it means that something is wrong with the thyroid gland because it is producing excess thyroid hormones and TSH is low. Now you need to perform the thyroid scan that we discussed about. You perform the radioactive iodine scan of the thyroid gland, and then if there is diffuse uptake, that is Graves' disease. If there is nodular uptake, there is one toxic adenoma that is producing it. If there are multinodules, and it means that there is multinodular goiter. I have talked about thyroid nodule workup in detail in my video on thyroid nodule workup. The link of that video is given in the description below. If there is no uptake, now you should know what can cause no uptake. It's thyroiditis. There is destruction of the thyroid gland with hyperthyroidism. Hashimoto thyroiditis, you perform thyroid peroxidase antibodies, anti-thyroglobulin antibody. Now would you be thinking that Hashimoto thyroiditis is a cause of hypothyroidism? It's a thyroiditis. Initially it would cause hyperthyroidism and later it will develop into full-blown hypothyroidism. Thyroiditis, exogenous thyroid hormone use. Patients taking thyroid hormone in excess. Maybe a patient was having hypothyroidism for which thyroid hormone was prescribed, levothyroxine was prescribed, but that levothyroxine dose is higher. Therefore, it is causing the symptoms of hyperthyroidism. Serum cholesterol level were elevated in hypothyroidism. Serum cholesterol level are low in hyperthyroidism. ECG must look for atrial fibrillation. Most commonly, you would see sinus tachycardia in these patients. Thyroid ultrasound is performed to look for thyroid nodule, and if you find the thyroid nodule, you go for FNSE. Thyroid nodule workup has been explained in detail in my video on thyroid nodule workup. So this was all about the causes, the diagnosis, the presentation of hyperthyroidism. In the next video, we'll be discussing in detail about the treatment of hyperthyroidism, how a patient of hyperthyroidism would present to you, and how would you treat that patient. So make sure to watch my next video on the treatment of hyperthyroidism. In summary, we talked about what is hyperthyroidism, difference between hyperthyroidism and thyrotoxicosis, Graves' disease being the most common one, iodine-induced hyperthyroidism, stroma ovary, pituitary adenoma, hydatiform mole, Graves' disease, look for the antibodies, diffuse uptake on the scan, pretibial mixed edema, ophthalmopathy in Graves' disease, toxic multinodular goiter, multiple foci on thyroid skin, Thyroiditis, we discussed that how there is reduced uptake and sometimes the antibodies can be positive. Initially thyrotoxicosis, later on there will be hypothyroidism, decreased uptake on the thyroid scan. Then we discussed what is iodine induced hypothyroidism, Jod Basedow phenomena. People living in iodine deficient area go to a area with more iodine, develop hyperthyroidism. Then we discussed Wolff Chaikoff effect with the story of Chernobyl. We discussed what is the epidemiology and what are the age ranges affected in the different types of hyperthyroidism, the clinical features, the symptoms in the eye, the lid lag, the lid retraction, the Graves' ophthalmopathy, cardiovascular signs and symptoms, AFib being the most common one. In the hyperthyroid myopathy, the CK levels are normal. In endocrine, abnormal menses, pretibial myxedema, thyroid acropathy seen in Graves' disease, neuropsychiatric symptoms, and then we discussed the workup of hyperthyroidism. And if the TSH is high, it is pituitary adenoma. If the TSH is low and the thyroid hormones are normal, subclinical hypothyroidism. To check for beta HCG in patients that are pregnant. Signs of Graves' disease are seen in these patients. Then you perform radioactive iodine scan where there are no signs of hyperthyroidism, and then you perform certain other tests as well. If you like my video, please click on the subscribe button and make sure to watch my next video on the treatment of hyperthyroidism. I have discussed ECG series in detail. I have talked about emergency medicine in detail. There are different playlists present on my channel. Make sure to check those playlists out. Thank you very much.